Myers. Thank you for coming.
Thank you for having me. Good afternoon, everyone, and I would like to thank the Press Club for the opportunity to speak with you guys today. As was mentioned, I'm Candice Myers. I'm an assistant professor at Pennington Biomedical Research Center. My lab focuses on the social determinants of health and health disparities. As mentioned, I have a degree in sociology, so that's how I approach the health research that we do at Pennington, is from the perspective of a sociologist. Specifically today, I want to talk about food insecurity and its associated health disparities in obesity and weight loss. So what are the social determinants of health and health disparities? What we have here is a definition from Healthy People 2030. Social determinants of health are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. We can see here on the diagram that Healthy People 2030 has put together. They kind of organize the social determinants of health into 5 broad dimensions or categories. These include education, access and quality, healthcare access and quality, neighborhood and built environment, social and community context, and economic stability. What's important about the social determinants of health is that they contribute to or underlie a wide number of health disparities and inequities. And so today I want to talk about food insecurity as a social determinant of health, and specifically it fits into the domain of economic stability because it is related to economic or financial resources. So what is food security versus food insecurity? Just to provide some definitions to orient everyone to what we're talking about. Food security is access by all people at all times to enough food for an active and healthy life. Food insecurity is kind of the opposite of that, or on the other side of that coin. It exists whenever the availability of nutritionally adequate and safe foods, or the ability to acquire those foods in socially acceptable ways, is limited or uncertain. So that's kind of a large definition for a word that essentially encapsulates the idea that there's not enough food to eat and there's not enough good and healthy food to eat. So it really is an issue of both quantity and quality. Food insecurity can impact the quantity of food that an individual, family, or household has access to. Importantly, food insecurity also impacts the quality of the food or the diet that an individual household, family, or household has access to. And because of this impact on quality specifically, we understand that food insecurity has a negative impact very often on nutrition and diet. So we see a poor quality nutrition, we see poor dietary intake when those individuals experience food insecurity. Importantly, as I mentioned, food insecurity is linked to compromised financial or material resources. So very often food insecurity is linked to poverty, being economically disadvantaged, being of lower socioeconomic status. And we understand that these issues are related to things like education, employment, occupation. And so again, as I mentioned, food insecurity really is a key social determinant of health because it's about those external factors that kind of characterize an individual, but it does have biological or even physiological consequences. So here in the US, how do we measure food security or food insecurity? And we do so with a series of questions about conditions and behaviors that characterize difficulty meeting basic food needs. And this measure was developed by the United States Department of Agriculture, and it's really the gold standard for measuring food insecurity and food security on a regular basis here in the US. It's the USDA Core Food Security Module, and it's comprised of 18 items or 18 questions. These reference the household as a whole, as well as adults and children that are present within a household when measuring food security status. If we look here at this graph provided by the USDA, we can see that there are a number of different conditions and behaviors they're actually measuring when we talk about food insecurity. Things like worrying food would run out, food bought did not last, could not afford balanced meals, actually cutting the size of meals or skipping meals, both short-term and long-term, eating less than someone feels they actually should, being hungry but not being able to eat, or actually losing weight, or not eating over the course of a whole day. So these are some of the things we measure when we talk about food insecurity. Typically, the module focuses on a time period of the previous 12 months, so over the course of a year. It can be modified to focus on 30 days or the previous month. And if there are 3 or more affirmative answers to these 18 items, typically that household is classified as being food insecure or experiencing food insecurity. So what does food insecurity look like in the U.S.? I really appreciate this map from feedingamerica.org because they map the county level food insecurity rate across the entirety of the U.S. And I think this is quite a graphic way to help us understand what food insecurity looks like in our country. And what we can see here in 2019, the overall county food insecurity rate in the United States was 10.9%. If we look across the U.S., we can certainly see that there are pockets or clusters of counties with greater or higher food insecurity rates. So those counties that are in the darker green, and we can obviously see that many of those counties are within our own state, but certainly across the U.S. south into Appalachia. And so, what does this look like in Louisiana specifically? I'd like to highlight our state. Here in 2019, the food insecurity rate across counties in Louisiana was 15.5%, which is greater than what we see at the national average. And so that's something for us to consider. Is obviously food insecurity is very prevalent within the Louisiana population, and we have some parishes here in Louisiana that are in the darkest green, where we can see that food insecurity prevalence is over 30% within those counties. Here in East Baton Rouge specifically, if we highlight our parish that we're currently in, we can see that the overall county food insecurity rate was 13.2% in 2019. So again, we're not above what we see in Louisiana on average, but we are above what we see in the U.S. on average. And so while we may have a food insecurity rate between 4 and 14% here in Louisiana, we certainly have other counties, or parishes rather, in our region that are adjacent to us that have much higher rates of food insecurity. So certainly something very prevalent within our own community. So not to hit on every piece of data here, but I think the overall takeaway in much of the scientific research that's been published to date is that food insecurity is linked to obesity. And so much of my research at Pennington focuses on this association between food insecurity and obesity. At Pennington, we really focus on obesity, diabetes, and cancer as those chronic diseases that we're studying. And so my contribution to our research mission at Pennington is to focus on food insecurity. One, because it's linked to obesity. 2, because it's very prevalent in Louisiana. And 3, because obesity is also prevalent in Louisiana. So we really have a kind of a trifecta of issues that are intersecting here. The takeaway that I would like to really focus on here is that food insecurity is linked to obesity, poor cardiovascular health, and diabetes. And so much of the literature shows that this is through the diet, which is obviously important, but it's also through stress as well. And so I want to talk more about a study that we currently have at Pennington that's looking or focusing more on the stress component of this relationship. So what have we done at Pennington that really contributes to this literature looking at food insecurity and obesity? One of the things we have done is looked at national trends in food insecurity by what we call adiposity, or a marker of obesity body fat among U.S. adults, specifically adults 20 years and older. We used the National Health and Nutrition Examination Survey, or NHANES, to do this. NHANES every couple of years actually visits Pennington with their kind of mobile clinic, their mobile health examination clinic. They park in our parking lot and actually survey and collect data from people here in East Baton Rouge Parish. Within NHANES, one of the questionnaires they ask is the 18-item U.S. Household Food Security Survey module, which I previously identified. Also, what they do within NHANES, which is really great, is they collect what we call body mass index. And so individuals are actually weighed in the mobile health clinic and their height is measured so that we can obtain their body mass index, which is measured in kilograms per meter square. From that data, we can further categorize people as well as having a BMI that falls into the categories of either normal weight, overweight, or obese. And so this is how we're actually able to measure obesity prevalence within the country and then within our own state and community. So what does food insecurity and obesity look like among U.S. adults? What we have here is the prevalence of food insecurity among U.S. adults from 1999 all the way to 2016. What I would like to point out overall is that in 1999, the food insecurity rate in the United States was 8.7%. However, that significantly increased to 18.2% over the course of less than 20 years, about 15 years. So we've seen almost a doubling in food insecurity prevalence here in the U.S. Importantly, what the NHANES data allowed for us to do is not only look at food insecurity prevalence overall, but we could look at food insecurity prevalence by BMI category, normal weight, overweight, and obese. The comparison that I would like everyone to focus on between these three categories of BMI is here in 2015 and 2016. We can see that among adults who have a BMI in the normal weight and overweight categories, the food insecurity prevalence was almost equal within these two groups, 15%. However, for adults with a BMI in the obese category, there's a food insecurity prevalence of almost 23%. What we're seeing here is food insecurity being more prevalent among adults who have a higher BMI, specifically a BMI that puts them in the obese category. One of the important things about food insecurity and obesity is that there's a potential sex disparity that's occurring in this relationship between men and women here in the U.S. So what we've done is we looked at our food insecurity prevalence, and we did so across the time period. And then we did it for men and women according to the BMI categories, again, of normal weight, overweight, and obese. What I would like to point out is if we look at this data for men, we can see that food insecurity kind of overall increased across our time period, but there's not a clear pattern based upon BMI category. However, if we look at women, we can see that food insecurity prevalence overall increased from 1999 to 2016, but we see a pattern based upon BMI category among women in the U.S. If we look at our normal weight and overweight categories of BMI, which are in blue and orange, we can see that they kind of hang close together. However, if we look at this gray line, which captures BMI in the obese categories, we can see that food insecurity prevalence is much higher across the time period, again indicating that the relationship we're seeing between greater BMI and greater food insecurity may be driven by women or be experienced most by women. So this is something we've been keeping in mind as we do research at Pennington, is this potential sex disparity that's happening in the relationship between food insecurity and obesity. So what can we conclude from this NHANES analysis? Food insecurity prevalence increased in the U.S. from 1999 to 2016 across all levels of adiposity, across all BMI categories. Food insecurity prevalence was greater in adults with greater adiposity or greater body weight. The disparities in food insecurity by adiposity between men and women is particularly important here, as women with greater adiposity were more likely to be food insecure compared to those with lower adiposity. And so these data have informed one of the current studies we have ongoing at Pennington. But before I talk about that study, I want to further talk about the discussion, the association between food insecurity and obesity, but I want to focus on weight loss. One of the things that's really important in our research at Pennington is the focus on weight loss as kind of one of the ways that we're treating obesity as a disease. Recently, the PROPEL trial was conducted here, kind of headquartered at Pennington, but it was really throughout the state of Louisiana. And the PROPEL trial was looking to promote successful weight loss in primary care in Louisiana. And this was a study that was funded to test the effectiveness of a pragmatic, high-intensity, lifestyle-based obesity treatment program in a large sample of underserved adults with obesity. And so there were 803 patients enrolled in this 24-month weight loss trial. Importantly, it was delivered in 18 primary care clinics across both urban and rural Louisiana, so places from all the way from New Orleans to Shreveport to even more rural areas in Louisiana. What's important is that the intervention in the PROPEL trial was health literacy and culturally appropriate. So it took into account the potential that patients may have issues understanding health recommendations, and it also was culturally appropriate in that it kind of recognized the unique culture we have here in Louisiana around food. And so the intensive lifestyle intervention was one arm of the trial, and it was the health literacy and culturally appropriate intervention. However, there was also a usual care arm, and these patients in the usual care arm essentially saw their primary physician on a regular basis, but did not receive any additional health coaching or health advice that those in the intensive lifestyle intervention received. Importantly, we looked at weight loss. So instead of just looking at BMI at one time point, we were able to look at changes in body weight across the 2 years. And in this case, for PROPEL, we measured food security status, not using the 18-item questionnaire, but we used a modified version of the questionnaire that was 6 items that also is health literacy appropriate, a bit more easier for people to understand. So what did we find in the PROPEL study regarding food insecurity and weight loss? Because at baseline, or the beginning of the PROPEL study, we actually executed that 6-item food security survey, we were able to categorize participants as either food secure or food insecure. And then based upon whether they were randomized to the usual care group, the UC group, or the intensive lifestyle intervention group, the ILI group, we kind of had 4 categories of patients within the PROPEL trial that we were able to understand if their food security status at baseline impacted their weight loss over the 24 months. And so what I'll point out here is that we had 233 participants that were food secure in the usual care arm. 323 were food secure and actually received the intensive lifestyle intervention. Of the food insecure patients, 118 were in the usual care arm and 129 were in the intensive lifestyle intervention. Overall, of the 803 patients in the PROPEL trial, over 30% were food insecure, which is much greater than what we see kind of at the national level. So certainly an underserved patient population that may be more vulnerable to socioeconomic issues in this trial. So while this graph is a bit confusing, what I would like to point out is we have our 4 groups of participants from the PROPEL trial over the 24-month period, and we essentially just looked at their body weight across that 24-month period at 0, 6, 12, 18, and 24 months. And so what did we find? We found that food insecurity moderated patient responses to the PROPEL trial. It actually impacted their weight loss. Relative to food secure patients, those who were food insecure and received the actual intensive lifestyle intervention versus usual care had smaller reductions in body weight over 24 months. So if we look at our bottom 2 lines here in turquoise and black on our diagram, those are our participants who received the intensive lifestyle intervention. Those in turquoise were our food secure participants, and we can see that they lost more weight than the food secure participants. While it's promising that our food insecure participants actually lost weight, it's somewhat disheartening to see that our food insecure patients didn't lose as much as the food secure patients. And so what this data really kind of brings to mind is more questions than answers for us. You know, we're further looking into that relationship between food insecurity and body weight, but what we're seeing is when we talk about weight loss and food insecurity, there's more that we need to do as researchers to actually elicit healthy body weight loss for food insecure people. And so food insecurity did significantly moderate patient responses to the PROPEL intervention. Relative to those food secure patients, those who were food insecure and received the intensive lifestyle intervention versus usual care had smaller reductions in body weight over 24 months. And so again, while those patients who were food insecure did experience weight loss, their weight loss was less than their food secure counterparts. So again, reason for more research into what kind of happened here. So with that in mind, what we're currently doing or recruiting for at Pennington is a study called Responses. And this is the effects of episodic food insecurity on psychological and physiological responses in African American women with obesity. So this is drawing from the literature and even our own research at Pennington that shows a positive association between food insecurity and greater body weight in adults. We're further focusing on the data that showed this association is strongest in women. But importantly, we're further focusing on African American women. And the reason why we're doing this is because compared to racial and other racial and ethnic groups, both obesity and food insecurity are more prevalent in African American women. And with that in mind, the prevalence of obesity itself is even greater in African American women with food insecurity. So what we're talking about is the intersectionality of being food insecure as well as being African American and how that impacts body weight. And importantly, I mentioned this previously, we want to understand stress as a central component in the pathway leading from food insecurity to chronic disease. How does food insecurity act as a source of stress, and does that potentially help us explain the relationship between food insecurity and obesity? And so this study is measuring the episodic nature of food insecurity, related stress, and the role of both psychological and physiological mechanisms in explaining this. So just to give you a broad overview of kind of what this study actually looks like, it's a longitudinal 22-week observational cohort study. By observational, I mean there's no intervention. We're simply following our women who enroll in our study over the course of 22 weeks and intervening in no way. We're actually enrolling 30 food insecure and 30 food secure African American women with obesity. We want both food secure and both food insecure women so that we can make comparisons between those two groups. We're collecting body weight daily via in-home scales. So participants who enroll in our study actually receive a Bluetooth-enabled Fitbit scale that they take home with them, and we ask them to stand on it every day so that we can collect their body weight. We're also doing weekly assessments of food insecurity and stress via short questionnaires wherein our study staff actually reach out via email, text, or phone to participants to ask them these questionnaires. So the psychological parameters are measured via a number of questionnaires, but we're also getting or measuring physiological parameters. And so one of the unique things about the Responses study is we're collecting both blood and urine. And so while that may seem a little odd for this type of study, it's really one of the more innovative components of this study because we're able to actually collect blood and urine to measure stress as a physiological response, things like cortisol and inflammation and thyroid function. And we're collecting those both at the beginning and end of the 22-week period. And again, those psychological questionnaires are also assessed remotely at midpoint. So we're getting a lot of data from this Responses study. And so one of the things I really wanted to plug today is we're currently about 50% enrolled, which is really great for this study. We're looking for more participants. And so to qualify for this study, participants should be an African American female between the ages of 18 and 65 and have a BMI between 30 and 50. If someone does not know what their BMI is, that is okay. You call Pennington and our staff will help you ascertain what BMI is. Participants will receive a Fitbit wearable. So we're using Fitbit senses in this study, and what this Fitbit does is we're asking our participants to wear it all the time. It measures their steps, some sleep parameters, even their heart rate. And so we're just getting as much data as we possibly can in what we hope is kind of a less intrusive way. Compensation of up to $200 is offered for completion of the study, and participants who actually complete the study also get to keep their Fitbit. So we're hoping that's a nice piece of compensation for people who may not otherwise choose to buy a Fitbit themselves. If anyone is interested in enrolling in the study or want more information, please reach out to our recruiting team at this number. This is what they're there for. They are great at what they do. We also have a landing page or web page for our responses study specifically. And then we also have Isabella Reed's contact information. She's kind of the lead for this study in terms of study staff, and she can answer any questions that you may have. And so with that being said, I also have some flyers for this specific study. But what we're hoping is that the data we collect via the responses study feeds back into some of the extant literature about food insecurity and obesity. We want more information. We need more information so that if we want to create weight loss interventions or health improvement programs, we need to make sure that we understand food insecurity is prevalent within our community, and we also want to find better ways to address health promotion and health improvement in food insecure populations. And so with that, I want to thank you for your time and attention today and for the opportunity to speak to everyone. This is my email at Pennington. Please reach out to me with any questions. Or if you want more information, I'm always available to answer questions and not just talk about this study, but we can potentially talk about any other studies with food insecurity and obesity that we're pursuing. And with that, I'll take any questions you have. And again, I appreciate your time. Yes.
So listening to your presentation, I understand the scope. What I didn't hear you touch on is, as you mentioned about women, is the impact of eating disorders in women, and having nothing to do with any social or economic thing, but just body image. So how do you remove that from the study? Because that is so pervasive.
Yeah. So the questions about eating disorders potentially having a role in the relationship between food insecurity and obesity. So the literature does say that among adults, those individuals who are food insecure are also more likely to display eating disorders or disordered eating. And that potentially relates to the fact that food insecurity can disrupt eating patterns. Also, there's the idea of this life course approach. If someone experiences food insecurity earlier in life, it can create or engender disordered eating patterns that carry on into later life. Hoarding food, being worried about food, constantly obsessive about food because of the lack of it not always being there, on a regular basis. So there is some data that shows food insecurity and eating disorders are linked. In terms of its relationship to women, I think one of the things that's unique here, especially about the responses study, but if we talk about it in adults in general, the responses study is focusing on African American women. But if we think about eating disorders, very often they're most prevalent in white women. And so in the case of this study, we're not controlling for them, but what we have is a series of questionnaires that tap into disordered eating, and our hope is that not that we can control for it, but we can even understand if eating disorders are potentially those mechanisms that are working in the pathway between obesity or body weight and food insecurity, because if they are significant, well then that's something that we can potentially address or try to modify in the next stage of developing an intervention for weight loss. Maybe we need to consider disordered eating as a potential correlate here. And in the case of Propel, disordered eating was not part of the intervention and it was not measured. So, yes.
Especially right now, in your study or now, if you know, the effects of inflation. I know there was a pandemic, now we're seeing terrible inflation.
Yeah.
How does that work into food insecurity?
Ted, would you mind going back through the slides towards the beginning where I have the U.S. Food insecurity prevalence? Yeah, that one right there. So the one thing I didn't talk about was this graph right here from the USDA. And so if you notice, data is from 2001 to 2019, so prior to COVID, okay? I do agree that COVID not only was a public health crisis, but a socioeconomic crisis, and now we have inflation that is really further exacerbating the issues that kind of started with COVID and are prolonging around food prices, employment, job opportunities, just all of those socioeconomic things. And so these data at this point don't account for that. But what I always like to point out, because I did some of this research during my graduate work, between 2007 and 2009, we had the Great Recession here in the US. And if you see, we have a pretty significant uptick in food insecurity rates at that time. We could probably make the conjecture that if we have these data through 2020, 2021, we may see an uptick that is somewhat similar to that. So yes, right now is a very complicated time here in the US for our society and our economy, because certainly food insecurity is probably doing something similar here where it's increasing and more families are experiencing it. And we know that lower income families are probably the ones who are experiencing it the worst. And so I think what's important is when these data, which are released every year by the USDA, when the new data come out and we actually see what food insecurity looks like, it's quite interesting, because what if there is an uptick that's then prolonged and we have more families that are falling into this food insecurity category? The health implications are kind of scary, at least from that perspective. And then how do we account for that as health researchers who are trying to address obesity? It's really quite challenging, because as you can see here, we're just now getting a grasp on what we need to do for food insecure people who have poor body weight and have poor health outcomes. Yeah.
To the extent that there are, I think, been policy responses in this area, they probably tended to be around two things: better nutrition programs in schools, expanding the number of people who are eligible, and so on. But also location of supermarkets and access to healthier. And obviously the stereotypical thing is somebody buying potato chips at the 7-Eleven instead of cooking stuff. And do you think that the study will provide any insight into those kind of questions?
This study, as it is currently kind of designed, it probably won't. This is, from my perspective, the responses study is really focused on the individual, and we're focusing on women. With that being said, we have to recognize that food insecurity very often occurs within the context of families and households because of shared resources within those households. One of the things I think I would like to point out about the focus on women and the link between food insecurity and obesity in women is the role that women play within our communities, in our society, in our families. Very often, women are child caretakers, they may be parent caretakers, they're potentially the ones providing or preparing meals, grocery shopping, making those monthly budgets. There's a lot of responsibility in that, and so very often women are they're carrying that burden more so than, let's say, men within that context, which may be why we see some of the data we see. There's also this idea of maternal deprivation, where women with children especially may deprive themselves of a nutritionally adequate diet, but make sure that their children are fed. And just for the reasons that you said, things like free and reduced lunches and summer lunches for kids. Kids are, really are fed within the context of schools very often for most of the year. And so those things are really important because they decrease the burden on families when kids have access to those. The thing, though, that I think is important is this, that's kind of coming about, and there's discussions about it at a more of a national level, is this idea of not just food security, but nutrition security. And it gets at what you're talking about, and it's the context of food, the food landscape, the food environment, our food systems, inflation. These are things that really affect everyone, not just people who are food insecure. And so it's making sure that people not only have access to food, but the food that they have access to is affordable, it's consistent, it's easy to obtain, just making, it's more from a health equity lens, because if we want everyone to to be healthy, we have to make sure that everyone has that equal access to food. And you're right, you know, there's a Rouge that's coming to North Baton Rouge that people have been talking about, and so that's quite, I know people are excited about it because that's, you know, it eases a transportation burden. It allows you to actually, while grocery stores are great because, yeah, they have potato chips, but they also have fresh produce, they have dairy, they have canned and canned goods, vegetable goods that are easier for people to access. If we can make it easier for people to access it, then, you know, we want people to have individual agency in the foods that they choose and how they choose to spend their money, but we also want to make sure they have access and actually have choices, because very often it can be an issue of just limited choices. Mm-hmm.
I don't know if you've seen any of the studies done or numbers coming out recently, but CPEC's put some numbers out
Mm-hmm.
that Black households are usually 23% food insecure, while white households are 7%. So I don't know if any of your literature that you review kind of touched upon any of that.
Yeah.
And that's here in Louisiana.
Yeah, I mean, that's exactly, so the responses study is funded by the National Institutes of Health, specifically the National Institute on Minority Health and Health Disparities. And that's because we, as researchers, we could have opened this up and just said adults, but we really wanted to focus on Black women as a health disparate population, because this is the group that needs the most attention. We need the most information because they're suffering, or they're, you know, that's where the problem is most pronounced. And this is just a building block moving forward to hopefully we can expand this to include other races and ethnicities, include other sexes, because the comparisons are what is also important. And talking about COVID-19 and inflation specifically, we know that food insecurity probably increased during COVID-19 and the pandemic, and is, you know, continuing to potentially increase with inflation. So the understanding is that African American families probably, because of the intersectionality with being lower SES, are probably experiencing that more acutely than other families that are higher SES. And so you're right, the health, from our perspective, it's the health implications of that that are really important. And how do we prevent obesity? How do we treat obesity if we have people who just don't have the consistent access to the things we're asking them to do? We're asking you to exercise, we're asking you to eat healthy. So for some people, it's just not as straightforward and it's not as easy to access.
When you, two things, when you say SES, what do you mean by that? And two, have there been any factors contributing to that disparity?
Well, socioeconomic status, so things like income and education primarily are kind of how we measure socioeconomic status. And in terms of those, for me, it's hard to treat things as mutually exclusive. Like I keep talking about intersectionality. Race intersects with SES, SES intersects with race, and so we need to not treat individuals as one thing or the other, but understand that all of those characteristics that complement them as a whole. You know, MDs spend the majority of their time focusing on kind of the biological and physiological components that impact our health. For me as a sociologist, it's those external things within our own communities that I think are complementary to what people are, what MDs do, or what other health researchers do that focus on physiology and things like that. Yes.
I was just going to piggyback on what Lanny said. I'm a state representative. In this session, one of the bills that I got passed was for food insecurities on college campuses.
Yes.
The hunger-free campus designation. But what shocked me was that I think the number I was given was almost 30% of our students on our campuses in this state have food insecurities.
Yes.
And I was in shock. And to have Jim Henderson talk about starting one when he was at Northwestern, and how they started it in a little room, and the students wanted to start a food pantry, and all of a sudden it exploded. So what this will do is encourage universities not just to have food pantries, but to have other creative ideas for use of meal tickets if somebody's not using them, informational services about where, you know, food can be obtained. But it was shocking to me just to learn that college students had such food insecurities. And it may go back to, you have single women, you have families, you have
non-traditional students.
college, and so, and I just noted the governor did sign the bill, so.
Good. Yeah, especially among first generation ethnic minority, college students, very much so, because it's the first generation entering college, and so they're coming from maybe more disadvantaged backgrounds. But the idea that, when I was in grad school, we called it the vow of poverty. You just took it and knowing it would pay off in the long run. But that suffering that you experience, especially during that transitional life phase of being a college student, is important because it does have health implications. It can potentially inform later life health behaviors and decisions. And so,
We're talking about the stress.
yeah, it is a stressor. I mean, you're trying to study. Being in college is stressful already. You're trying to study, you probably have a job on the side, and you don't have consistent access to food, so you probably don't have a healthy eating pattern. We know healthy eating is important for stress management. It's just kind of a vicious cycle. With that being said, I also believe I heard that there are some local high schools here in East Baton Rouge that are opening pantries so that the kids can actually take food home at night or on the weekend, just for the reasons you say, to make sure they have a meal when they go home, because it is prevalent in our community. And kids, the evidence between food insecurity and, let's say, body weight in kids is a bit more mixed, and it's just for that reason. They're situated in families, their parents may be able to protect them from it, but sometimes their parents may not be able to protect them from it. And so we do have these, these school-based resources, these federal programs that help kids, and up until they're 18. There was even a point in time where if you were in college, you could not qualify for SNAP,
Well,
what we call
that's
foods.
kind of
Yeah.
where a lot of these
So they're
students find
expanding
themselves.
that.
They don't have something that they can qualify for.
Yeah, it's important because it is something. Food insecurity is a social determinant of health at every life stage, and yeah.
Well, and obviously it varies greatly. I have wealthier and healthier friends who can go to resorts and get their eating in order. But from what exactly are the interventions in the Propel study that are made to encourage people and to bring them along on that? And how much do they interact with the access question?
So in Propel, the intensive lifestyle intervention, it was situated within primary care clinics. It utilized health coaches embedded in those clinics. So those health coaches were trained community members and they were trained, given information to interact with participants to give them health information about reducing caloric intake or increasing their exercise. And from what I understand about Propel is even during the first 6 months of the intensive lifestyle intervention, some participants were actually given portion-controlled foods like shakes. So that may not be something people regularly have access to, is let's just, a portion-controlled food or a portion-controlled shake that helps set them on that path towards reducing energy intake a little bit, and just, here, you eat this, don't think about it. For a lot of people, food consumes their thoughts all day, every day. It's either what am I going to eat next or how am I going to get my next meal, and that, that can lead to that obsessive thinking potentially. So Propel was really about consistent contact from the health coaches, especially during the first 6 months, which is when you really saw a lot of that weight loss. It was very intense for just that reason. Whereas with usual care, they maybe saw their doctor every 6 months or once every 12 months with no additional contact from a health coach or no additional information. Yeah.
We have time for one
One
more
more.
question.
Ooh, I'm sweating.
If not, thank you, Dr. Myers.
Thank you so much. I do appreciate this. Thank you. I think if I could get it boxed up to go.
Oh, yeah.
I really do appreciate it. That's it right there.